So we're introducing Mariann Yeager from the Sequoia project, who's going to spend the next several minutes talking to us about her activities, maybe, with the interoperability that Michael talked about. Do you want up there, or you want to? Okay. All right, so here's Mariann Yeager, Sequoia project.
Well, thank you so much for inviting me to chat with you today about our work at the Sequoia Project. I'm Mariann Yeager, CEO of the Sequoia Project, and I've had the honor of serving as CEO since the inception of the company in 2012. So hard to believe it's been 11 years. So, okay, thank you. Better? All right, so we have a very lofty vision, and that is to make the right information available at the right place and time to improve the health and welfare of all. But what we really do is we mobilize a community of public and private stakeholders to figure out what problems exist that impede the ability to share information and systematically solve them. So convening is very much part of our DNA, and that is actually part of the symbolism of our name, the Sequoia Project. So if you're familiar with sequoia trees, they're among the tallest and oldest trees on Earth. And if you ever see a sequoia tree growing alone, they don't quite reach the height of the great sequoias, the giant sequoias. Rather, when they grow together, they have an interconnected root system that supports their growth and evolution over time. And that's how they reach great heights. And that's really what Sequoia is all about, is bringing people together. We do this through two programs. The first is our Interoperability Matters program. I'll talk a bit about what we're doing there, and the work that we do with the federal government on TEFCA. And I believe you heard from Mickey Tripathi, and have the pleasure of working with him and his team, and I'll share a little bit more about that. So Interoperability Matters is a public-private cooperative. We bring together stakeholders from government and industry to identify, prioritize issues that are national level in scope, that can really only be solved by bringing together different perspectives, because with interoperability, if one party agrees to share information in one way and the other doesn't, then you have this disconnect and information doesn't flow. So it really does require that coming together. And what we focus on are issues that are not conceptual. There are plenty of think tanks and other groups that can do phenomenal white papers and whatnot. We're really, really rooted in real-world implementation. So if those three things exist, that's something we'll pay attention to. But our priorities are actually set by our community. So we do surveys about every year or so and identify, what are the pain points that exist that are impacting your ability to share information in the practical real world. So we know that there are important future innovative things. We tend to focus on the things that we can affect within the next 18 to 24 months. So we're very focused on real world implementation. Our community prioritizes what we work on, and then we work only on issues that we think we can actually substantively solve or progress. So these are the issues that we're working on. We started when we formed Interoperability Matters program in the fall of 2018 on information blocking compliance. And that was even before there was a final regulation. We knew that if you're not blocking information sharing, that it's sort of the same issues of figuring out how to share information. And so that's really our wheelhouse. Anything policy, technical related to facilitate the sharing of information is really where is our strong suit. That group has been convening for the past 3.5 years and actually came up with really wonderful substantive resources and guidance and best practices. We actually submitted to ONC about 80 questions and our interpretation of what the response to those might be. And lo and behold, their frequently asked questions on information blocking compliance reflected those. And I think we had consistent interpretation of those rules with the exception of maybe one issue. So we tend to operate, actually not unlike WEDI, is that we ourselves work to offset the burden of government and to promote interoperability for the public good. So government is involved in everything that we do. We have governmental liaisons on our board of directors. Government is involved in all of our work groups. And so we really try to be an extension of what is difficult sometimes for government to do. Well, we'll step in and we can kind of do the things that they may be more constrained to do. And information blocking compliance was a good example of that because our community was very in the weeds of figuring out how to make it work and apply it. The second issue that was identified was a recognition that the quality of the data being shared is pretty poor. So, there's some successes we'll celebrate in terms of the level of connectivity that exists in clinical information exchange. I can provide some statistics out here in just a minute. But I like to say we've done a good job of, now we have indoor plumbing only to discover the water is not potable, right? So, and I always said, we'll know we're making progress with interoperability when clinicians start screaming about the data being poor quality. Well, they're screaming, right? Rob, you know this. They've been saying this a long time. So to give you an example of the level of information sharing occurring, there are numerous nationwide networks in the U.S., eHealth Exchange, Commonwealth, SureScripts, among others. And then there are vendor-based networks such as Commonwealth, not Commonwealth, but Epic, Care Everywhere, AthenaNet, and others. And we brought together an initiative back in 2014 called Care Equality to interconnect those networks, much like telecom did back in the day of, when our cell phones, when they first came out, you couldn't call people who were part of a different carrier. Now that you can call anyone in the world, we did that with health information sharing networks. And Care Equality, today I just talked to my colleague Alan Swenson, who runs Care Equality, 500 million clinical documents exchanged every month between networks. That doesn't even count the number of volume of clinical documents exchanged within each network. The reason why I mention that is there is a tremendous amount of clinical information sharing occurring, but we haven't quite hit it quite yet on data usability. So we do have a work group on that. I'll do a little bit more of a drill down on that because we actually spun out an initiative to take that forward. We have a group focused on public health. They captured lessons learned from COVID. And not surprisingly, many of the learnings were policy related. And so we came up with sort of guidance, and there's a community of practice around that with public health agencies representing different states and jurisdictions, as well as CDC, ASPR, among others. We had our inaugural consumer-oriented group last year. This was a work group of individuals, patients, and caregivers who were not health IT insiders at all. They represented all walks of life, socioeconomic backgrounds, geography, et cetera. And we call them our Consumer Voices group because, part of our work at Sequoia is to promote and enable the exchange of information for us as individuals so we can use our device and platform of choice to access our own records. And so we realized, well, we understand the policy issues really well. We understand the technical issues really well. And there's I can tell you the reason why it's not occurring today, even though the capabilities exist. It's a policy issue, namely a HIPAA privacy limitation. But what we realized we didn't have was the perspective of individuals, the average person. And so this group was fascinating. So we published their recommendations earlier this year. We actually have one of the women who served on the group is going to be speaking at our annual meeting next week. And what we learned was how we are not prepared as a country to actually operationalize an individual's access to their records. And it's for several reasons. Standards exist, policies exist, the devices exist. Because people generally don't understand their rights to the information, they find it very difficult to navigate these clunky portal situations. And so a lot of it was more around cultural education and awareness. And so we have a lot of work to do as a country. If we really want to enable individual access and promote consumer engagement, there's much more that needs to be done. So building out of that, we are launching a consumer engagement strategy group next year. And that group is going to focus on what can we, Sequoia, do to mobilize our ecosystem to prepare. And that is going to involve a lot of education and whatnot, but there are more things that need to be done. And this will also feed into the work that we do with TEFCA. So everything I'm talking about here, we can't unlearn or unknow things once we are working on something. Everything feeds into TEFCA and our learnings. There are 2 new groups we are launching next year. Really jazzed about these. Privacy and consent. And so we realize that HIPAA has a lot of limitations, and sometimes it is an impediment to information exchange. And I mentioned that the reason individuals are generally, even if the capabilities exist and the platforms exist to request your records, nobody's going to respond with the information. Do you know why? Because the likelihood that patient identities will not match and that the wrong person's records will be released inappropriately represents a HIPAA breach. And so providers and covered entities will not respond to requests to an individual's information because of the concern around a HIPAA breach. So that's what we're talking about. So privacy and consent will look at data segmentation for privacy and looking at what it can take to actually practically move that forward, and also looking and unpacking some of the complex issues around consent and consent management. The next group came about from a payer focus group, and we were talking with them and said, hey, what are your challenges? What are you tripping up on? And they talked about a couple different things, and then we talked about, the CMS rules and this whole payer-to-payer API. Well, nobody has it figured out yet. We thought, what? Are you sure? I mean, we were talking to big payers, right? And they said, well, we're figuring it out partner to partner, but most payers haven't figured it out, or it's just in the sandbox. And it would be really a great resource if Sequoia could come together and, really work on and come up with an actual implementation guide, best practices, et cetera. So all of these groups generate actual work product that is either guidance that can be used by those who implement. Sometimes they're implementation guides in their own right, or they're policy feedback to policymakers. So that leads us to, well, what good is an implementation guide if it just sits on the shelf? So we knew that with data usability, we heard loud and clear that this is of paramount importance to all, to providers, to payers, for clinical research, for really any data company, AI, you probably want good data, right? So we decided it was time to really create a movement around improving data usability. And so we love our tree analogy, so it's a data usability taking root. And so the work group that I mentioned earlier developed a single implementation guide that identified high-level use cases and to get consistent guidance on the elements that could be implemented within an 18-month period. So again, there are things that we could focus on. I mean, this is going to be a decade, 20-year-long journey, right? This is not a short-term thing. But they focused initially on provider to provider, provider to public health agencies, and between a healthcare entity and consumer. Knowing that this was the first version, the idea was to work on draw from existing resources, but to get some harmonization, consistency among them. So the work group creates the implementation guide. Now the data usability taking root movement implements it. So we brought together stakeholders, again, public and private, who made a public commitment that they would either support it. So say it's a group like a HEMA, they don't really implement the guidance, but this is a really big issue for health information management professionals, as well as provider organizations, governmental and private sector, as well as payers and vendors. And they came together and said, some of them said, we'll support it. Others said, you know what, we will pledge to implement this guidance. And we're talking big names, they're on our website. And others said, well, we'll sponsor it or whatever. So AHEMA co-sponsors this initiative with us, and it's all built around having roundtables and building a community of practice to share experiences on how to implement this guidance. We, Sequoia, have subject matter expertise in this area, so we provide technical assistance for those who participate. We actually have a test tool to actually test for data usability, and then we'll have in-person meetings. So we did have an in-person summit in September 6th. So this is an example of what is in the implementation guide, and I am not a subject matter expert, so this is about as far as I can go. But the idea was that there were these 6 domains, different topic areas that were prioritized. The work group prioritized these. Interestingly, the work group had about 340 people on it. There are probably about 30 to 40 that participate. It's open to the public. Anyone can participate. All of these resources are publicly accessible. And what we realized was, wow, maybe we should run these priority areas, and there might maybe 38 pain points as an example, past a roundtable of clinicians. And do you think the priorities that this broader work group had and those of clinicians were the same? No, they were not. So we felt it was very important that clinicians should really set the table. I know when I go to receive care for me or my children, I really care that they have the information they need to treat me. I mean, it's kind of selfish, to be perfectly frank, but it's important. So we did that intentionally to make sure that we were focusing on the things that would actually have import. So you can see data provenance, traceability, data integrity, effective use of codes, tagging, searchability, reducing duplicates and narrative. So now that we brought this group together, they are looking at this guidance. We actually have a checklist or scorecard for people to track their progress, and we are asking them to identify which elements can they implement and in what time frame. And there is a commitment to do this. And so we will actually have each of the implementers sign a letter of understanding that once they do that analysis, they will make a commitment to do that. The reason why, even though people can sort of walk back from a letter of understanding, is it requires a level of formal approval. So if you have Epic and Oracle Cerner saying that, signing a document that they're going to do this, they're darn well going to do it, right? So they take it very seriously, and it has to be approved up the chain. So again, these are the use cases. The way it's structured is each section has a problem statement. It outlines the use cases, the workflow for each. It points to existing published work and then provides guidance on harmonizing it. So super practically oriented. Some of it is just kind of no-brainers. You would assume it exists, and others a little heavier lift, but it was all intended to be doable in today's time frame. So that's what we're doing around data usability. Again, that was a pain point. Had a work group, work product, now we're implementing it. So with that, I'll move on to what the other hat we wear, which is working with ONC as the TEFCA recognized coordinating entity. And I know you heard from Mickey Tripathi. I'll provide a little bit more color here. So ONC was directed by Congress in the 21st Century Cures Act to develop or support a trusted exchange framework and common agreement to enable the exchange between and among networks. Now, if that sounds similar to care equality, it's because it is. We were briefing the Hill as they were writing 21st Century Cures, and they thought it was such a great idea they wrote it into statute. So we weren't sure how we felt at the time, but I guess it's worked out. So, but the goal was to establish a universal floor of policy and technical requirements to enable the exchange of information nationwide. The second goal was to make it simpler, because there was a proliferation of these networks. At the time 21st Century Cures Act was passed, care equality was in its infancy. I mean, transactions just were shared in July of 2016. Law was passed in December 2016. So in the event the private sector didn't really carry through, they wanted ONC to have the ability to step in. And, you know, the private sector has done a pretty phenomenal job enabling the exchange of information for treatment purposes, but there are others that aren't really as mature, and that's where ONC stepped in. So the idea was to make it simpler so that there was sort of a gateway to this nationwide connectivity, and importantly, to make sure that this will enable individuals to gather their information. So those are the goals. So this is how TEFCA works. So ONC owns TEFCA. They will retain certain inherently governmental functions, such as approval, governance. We work with ONC under a contract. We started working with them in 2019, then under a cooperative agreement, and we're just awarded a contract. It was, believe it or not, the first time we actually accepted federal money. So we were a nonprofit startup. We kind of started the old-fashioned way with building value and being sustainable, and then we're working with ONC on this. But our role is working with ONC to operate the program and to develop the components of TEFCA based on our decade-plus experience, and to operate the program. And we are the only ones who can actually evaluate and designate TEFCA qualified health information networks. So these are networks that have agreed to abide by the rules of the road in order to be recognized for TEFCA. These, I would say, are like super nodes, high-performing, high-resilient, high-volume, more akin to the telcos than regional and statewide HIEs, right? So everyone has a conduit to connect to a QN. Each QN in and of itself represents a number of connected participants and sub-participants. And so that's what we're doing. We actually were brought on the inside of a government policymaking process, which is super fascinating, right? So at first it was interesting to try to bridge an office that is very focused on rulemaking and try to help them understand, but this is operational, so that sounds like a good idea, but it'll never work, so we're having those kind of conversations. Phenomenal team. So we work as a joint team. It's not the ONC team and the RCE team, it's our team. And so it's been really, particularly with Mickey's leadership, has really brought everybody together with a healthy dose of practicality, which I really respect and appreciate. So these are the things that we've been working on. These are the components. So ONC developed the Trusted Exchange Framework. Those are the policy guardrails. The common agreement is actually a legal agreement that is a trust agreement, and it has all the obligations that QHINs must abide by, and also has some flow-down obligations to the providers, networks, payers, public health agencies, apps, whatever, have to abide by as well. So those are the flow-down terms. The first version of that was done in January of 2022. We're working on version 2 right now. There are also standard operating procedures which spell out more detail about how this would work. Think about things like governance, security incident response. You're not going to bake everything in a contract. You want the terms that aren't going to change likely. Now, who signs that contract is the QHINs and RCE. So that's who's party to that. And there are also standard operating procedures to explain how to implement certain use cases, such as individual access, public health, payment, healthcare operations. So we're working on some of those as we speak. The QHIN technical framework is the implementation guide. Onboarding process is what we're going through right now to actually evaluate whether these networks really pass, all the requirements. Once operational, we'll gather metrics and have governance. So those are the components. Everything is pretty much developed. We're in the process of onboarding. So this is where we are in terms of onboarding and designation. So there are, the first step in the process is someone has to submit a letter of intent to say, yes, we're interested in applying. Now, sometimes people do that and realize, it's not really our thing. We're not really made out to be a QHIN. Maybe we're a health IT vendor and we don't have the governance to govern this network, right? And its users. So we have 4 of those who are actively working on it. The next part of the process is submitting an application. We verify whether it's complete or not, and then and if it is complete, we accept it and we do, more substantive review. So you can see we have a couple folks in that part of the process. Once they're accepted, they do conformance testing. So we have several in conformance testing. Once successfully completed, they do partner testing. So we have 3 candidate QHINs doing partner testing. And once they complete that and they complete their project plan, because they have to provide all kinds of evidence about their financial sustainability, about their security posture. There is a tremendous vetting that goes into this because this is part of critical infrastructure for the U.S. and might be a healthy target too, right? So we've got to really, really make sure. And once they complete the project plan, then they're designated. We will have an initial group of QHINs designated this year. And they're like this close. So it's very exciting. So what will they do once in production? I think Mickey might have shown the slide. So QHINs must support and may only exchange information for 6 purposes. And these are generally defined by HIPAA, so treatment, of course, care coordination, payment, healthcare operations, public health, government benefits determination, and individual access. 2 of these a QHIN must respond. So if you're connected to a QHIN, unless you're prohibited by law, you have to respond to requests for treatment and you have to respond to an individual's request for their own records. Right? So again, right now with the current paradigm, that's not, and we're writing implementation SOPs right now for payment and healthcare operations. A draft will be published for public feedback at the end of this year. We've already been doing a ton of stakeholder feedback. And we do have monthly informational calls open to the public, so welcome that. All this information is on our website. We're also working on a public health implementation SOP. You would think, well, if you can do it under HIPAA, just share information. Well, guess what? Nobody's going to do that because there's too much nuance. You've got things like minimum necessary. You've got this thing called trust. Nobody really, this is fairly untapped. Until we get an SOP out there for payment and healthcare operations, that is our mechanism to get payers to the table. So payers right now have been somewhat on the sidelines of the clinical interoperability space. So this is the conduit to bring them into the fold. And also public health. And this is where Mickey is, oh my gosh, I told him, I said, when he first took that role, we talked about it, and he said, well, what do you think would make TEFCA successful? I said, get the federal agencies at the table. So CMS is a payer. Why aren't they a party to exchange? They're more than a regulator, right? Well, get the CDC to the table. And, and also making strides in these other purposes. Treatment, again, we've got that fairly covered, but these other purposes are what's really novel. So here are the capabilities that were first to market. It's query for documents and push. And so, again, they have to support that. This was sort of low-hanging fruit because these were capabilities that were readily implementable and very mature. And so that's what we started with. And, of course, FHIR. So there was a multi-year roadmap. So you can exchange out of the gate FHIR content in an IHE exchange that's supported today. But now we're working on, and we have an implementation guide that's been published. It's been piloted around facilitated FHIR, so that's point-to-point. We have commitments from the candidate QHINs to implement it in 2024. And people say, oh my gosh, why didn't you start with FHIR? Why is it taking so long to get to FHIR? Well, did you know that certain capabilities that are needed to support FHIR at scale were never tested until March of 2023? So you kind of need to test it if you're going to put it in the real world. So the idea here was to create a point-to-point FHIR-based approach without manual intervention that also had a high degree of security and adopted a well-designed set of standards, including the U.S. Core and Da Vinci implementation guide. So the idea here is to point to other existing resources, not to create something net new, right? And then be able to track where documents are converted and how. So security is absolute imperative. Nothing happens without it. And so we will have TEFCA certificates for authorization authentication. We also will be adopting UDAP. That is the capability that had never been tested between two unaffiliated partners until March of 2023. Hard to believe, but it's true. And then, ensure that the data holder knows who the person and organization is requesting the data. So with these capabilities, this will address the concern that exists with document-based exchange so that individual access will be enabled by this, and we know that supporting FHIR is very important to the payer community, so this is a high priority. It is based on FHIR R4, which is the same version that is pointed to in regulation, and it points to the widely adopted IGs, and so we are requiring use of Da Vinci and CARE and FHIR implementation guides for payer data exchange, so we listen. People say, use what we've developed and what we want to support. Great. If you will participate, we will do that. That is a great idea. And then if there are data are transformed from document-based to FHIR, that understand how that was done. So this has surprisingly a tremendous support all the way up to the White House. And there was an event celebrating the first applicant QHINs in March of this year. It was hosted by Secretary Becerra. And so you can see, and there were speakers from the VA and the DOD and CMS and CDC, and it was kind of a big deal. And so similarly, there's equal interest in maintaining that level of continuity and seeing this to fruition. So here is the timeline. You could see it was sort of a slower start, but once it got going, you can see everything is measured now in weeks and months. So we will be live in December. And by the end of this year, and then we'll be rolling out other versions of the Common Agreement in QTF, which support FHIR-based exchange. That's targeted Q1 2024, and then the rollout thereafter. So that is a little bit about us and what we do, and I'm happy to take any questions if there's time.
Any questions?
Yeah, I think there's.
I'm already ahead of you.
So can you shed a little bit more light on how HIPAA impedes information exchange? Because I think I got stuck there, and it will help if you throw a more light on that. Thank you.
So how will exchange occur?
Yeah, how the HIPAA privacy rule.
How the HIPAA
impedes-
privacy rule?
Yes,
Okay.
how it impedes the information exchange.
Yeah. Okay. So the Common Agreement basically points to HIPAA as a contractual standard of performance. And so one of the big, and other than a governmental agency, which is subject to a different body of law and regulations. So the thing that the Common Agreement does is it establishes HIPAA as the floor. So we know app providers, for instance, and there are others that are not subject to HIPAA. So if you participate in TEFCA, you're expected to comply with HIPAA as if you were a covered entity. Also, for app providers and anybody who supports individual access services, is obligated to a much more rigorous set of restrictions and requirements because they're not regulated by HIPAA, so we can regulate that by contract, but there are further stipulations that they have no rights to the data that they hold and that they have to encrypt it at rest and in transit, where the rest is, others just have to encrypt it in transit. So it's a big deal. This contract is sort of, it's like a treaty, you know? I mean, it covers the full gamut of uses, disclosures, obligations to respond, security obligations, which is a high bar. I mean, these KNET QHINs have a very high bar for security. We'll have a cybersecurity council that'll convene as soon as we have the initial designated group, and it's something we'll continue to work on.
We have a question online. Is the go live on version 1 or version 1.1 of the Common Agreement?
So version 1 was published in January of 2002, or 2022. Oh my gosh, yeah, that would have been a long time ago. And there was a version 1.1, which was published about a week ago, and there were changes that HHS needed to see in place. Things around decision-making and appeals that, again, these are inherently governmental functions, and it wasn't, the Common Agreement, the language wasn't specific enough, so there were just a handful of changes there. So the 1.1 is absolutely the version that will go live.
Mariann, first of all, thanks so much for being here and phenomenal work you and your team have accomplished. You know, the list of your 6 focus areas, this audience in particular, very interested in payments and healthcare operations. Can you give us sort of some specific examples of how this flow of data is really going to help in that area and, of course, supporting value-based care?
It's a great question. So, you know, when we first put forward the implementation SOP for payment, it included payment and healthcare operations. We had extended targeted stakeholder feedback sessions. We're very transparent. I mean, every month we have this call. This is what we're working on. Sometimes we've made progress in one area, sometimes we haven't, and we always take every feedback. We initially proposed, because we heard from a certain group that risk adjustment would be a great place to start. And then when we put that out as a proposal, realized, oh, wow, there are certain groups that said that is not the right place to start, walk that back. So we're looking at, so anything covered in the HIPAA definition of payment and healthcare operations is permitted under the Common Agreement, but the SOP is going to more narrow it down a bit further. So right now we're focused on a subset of healthcare operations functions, not getting more specific than that. And for value-based care, we're working through some very interesting issues as we speak, because there is an interest, we know, of ACOs in participating in TEFCA and accessing data from TEFCA participants, but not necessarily a willingness to share the data they have. So we're trying to marry that up. But once operationalized, and we will have a draft out for public comment in December of that SOP, really encourage you all to read it. You'll, I think, see what's capable. But we have to balance what is palatable by all and where there is reciprocity. So, for instance, payers said they're very willing to participate in TEFCA for healthcare operations, and they're also willing to share their claims data back with the providers, so there is that reciprocity.
We have a question over here.
Yes.
Thanks, Mariann. Is the payer-to-payer work group accepting new participants?
Yes.
Okay.
Yes. So we have not launched that yet. It's chartered. The group is chartered. We are identifying folks to participate. We have a lot of interest in the Sequoia community in that group, and definitely welcome others as well. Yes.
Me? Great. Mariann, incredible work. Sequoia Project is a beacon of hope in healthcare and health information exchange. It's incredible what you do. Simple question, I hope. I know the requirements for QHINs and what they have to meet. In terms of their participants and sub-participants, are flow down requirements that are the same for them as for QHINs? And if not, consider a small sub-participant. They may not be able to afford those requirements. How is that handled in TEFCA?
So the flow down provisions are a small subset of what a QHIN is expected to do. So it's more around appropriate use and disclosure and security, incident response, breach notification, things like that. It's and that anything that's a compliance obligation is really light. I mean, it's intended to be scalable to the smallest organization to the largest payer health system. Yeah. Got to make it easy too.
Let me go back in time. Soon after HIPAA was passed, Congress stepped in and said, we are not going to authorize a national patient identifier. In 2013, the WEDI report identified that as a very vulnerable area for data exchange. Can you discuss how are the QHINs, how are the participants going to ensure that the right patient is identified for the specific record?
It's a good question. So it's less of an issue where there is an organization that has a direct relationship with the individual. So with payers, they have the member ID. That's a great secondary identifier used for matching. And then the same for providers. And with the apps, cell phones, I mean, there are ways. It's improved dramatically. I think there was some research Regan Streep did a while ago that said, unique patient identifier might help maybe 7% of the population or something like that. So there is a high degree of expectation around identity proofing and verification, and that's supporting FHIR-based exchange. We anticipate a higher degree of assurance of that.
Couple questions here online. You mentioned payers are not active participants in this exchange. What value propositions do you think would be needed to enable their adoption?
The data, they need more data than what's in a consolidated CDA, for one. So it's about the data. Second would be supporting FHIR-based exchange. And it was really around the business case, the use case, so healthcare operations. It was tricky. I mean, Care Equality has been trying for several years to work on a use case for payment in healthcare operations and got consensus up to the point of actually adoption. And there are just these real concerns. I know this is probably shocking that providers don't really trust payers. I mean, I know, right? And it's ironic because most of these providers are under contract to provide the data anyway, but there's just concern about if they share this data, it's going to be used for contract negotiations and things like that. So I think what's going to happen by having a government-endorsed approach, because that's what TEFCA is. Government is saying, this is our stamp of approval. And, if you do this, it's a good thing. I think it's going to take that to move the market.
Final question here online. Can you provide any specifics of the FHIR support expected for TEFCA and the related timeline?
Well, it'll be the FHIR R4 guide. The draft guide's been out there. It's been piloted. The candidate QHINs are implementing it, and we have folks who said they'll go live in 2024. Now, some folks said early mid-2024. Others said later. We're working with them. Right now, they're really focused on go live, to be frank. So, all right.
Any additional questions here in DC?
Well, thank you so much. Appreciate you having me here. It's good talking to you all.